All right. Let's see. All right, so the two cases we presented last time are both autoimmune diseases, so rheumatoid arthritis and systemic lupus erythematosus. So the SLE is kind of a prototype of autoimmune disease involving many systems. So in general, we divided autoimmune disease as organ-specific versus systemic autoimmune diseases. So for example, you can have autoimmune disease affecting the thyroid, for example. You can have the so-called Hashimoto thyroiditis or Graves' disease that's both affecting the thyroid gland specifically, and there's no obvious other organs get affected. As the fact of this autoimmune disease like Graves' disease result in hyperthyroidism versus Hashimoto's thyroiditis will result in hypothyroidism, means low thyroid function. And in so-called systemic autoimmune disease like lupus, as we mentioned in the case, they can involve many different organs, or almost every organ system can get involved. And so that's some of the difference. There are many autoimmune diseases. I don't even have a accurate number of contents for that, but over 100 different type of autoimmune disease have been described. And the other concept I wanted to say about autoimmune diseases is so-called autoimmunity. You can have the status called autoimmunity, but does not necessarily to express as autoimmune diseases. That means if you do test in some seemingly healthy person, you might be able to find they have autoantibodies, or they can have autoreactive T cells. The good example is in we call it like at-risk populations like rheumatoid arthritis. The autoantibodies like rheumatoid factor or ACPA, the anti-citrulline protein antibody, can exist in the patient's circulation many years before they develop clinical visible rheumatoid arthritis. So the longest you can detect, or we have been find, was about 14 years prior to the onset of clinical rheumatoid arthritis. They already have those autoantibodies developed.
Did you say 14?
14.
Okay. Sorry,
So
just making sure I heard correctly. Thanks.
Sure, it's over a decade, roughly. I mean, you can see those, but that's the the time the test. I mean, samples available we can, but if you see, for example, trace back to 20 years, they might have it, but we just don't know yet at this point. So anyway, so that is pretty much also similar to like lupus. And in so-called healthy populations, if you wanted to test their blood, you can detect positive anti-nuclear antibodies. That's really true in a quite significant proportion of so-called healthy populations. And there's studies estimated about like 10% of populations, if you do the test, they might have different degrees of anti-nuclear antibodies. Some of them might develop clinical visible lupus, but majority of them will be like asymptomatic, or they just have this autoimmune status, but never develop auto antibodies. So we mentioned about the sex distribution in major autoimmune diseases, and over the chart you can see that from this end is a Sjögren syndrome with much more prominence of the women's versus the diabetes. So among all these major autoimmune diseases, look like only the type 1 diabetes is having male predominant slightly, but majority of them are female predominant. So raise the hands who has questions.
Oh, yeah. Is the autoimmunity sex ratio also reflected that in that? Would you see the same sex distribution for the autoimmunity as with the actual manifestation of the disease?
That's a good question. So I'm not quite sure we have the data to demonstrate that.
Okay.
Yeah, that's a really good question. So that's require a large number of population studies.
Yeah. I mean, yeah, you'd have to screen and then see who developed that disease. So yeah.
Yeah, exactly. That's really a hard thing to do. Doing those tests is not easy as like measuring, blood sugars or blood pressure. So that's the difficulties to find those populations. Okay, let's see the next one. So I mentioned about anti-nuclear antibodies. So this is an example of the anti-nuclear antibody being tested. And I think in general, for lay people, people believe if you have the anti-nuclear antibody tested, they automatically related to lupus. As shown in this table, there's a majority, like a whole variety of different conditions can be associated with anti-nuclear antibody test. So lupus by far probably the most commonly seen, but like a scleroderma, so-called mixed connective tissue diseases, and so on, you can readily detect anti-nuclear antibodies. So in other words, so once you get the positive anti-nuclear antibody test, that not necessarily means you have lupus. So it had to be differentiated by looking at the other tests and the clinical manifestations. And even so, in non-rheumatic diseases, like what I mentioned, like I mentioned like a thyroid disease, like a Hashimoto thyroiditis, you can have half of the patients would have anti-nuclear antibody test. So those are the things we often, say that in clinical practice. Patient has some other symptoms, joint pain, or then they detect anti-nuclear antibodies, and they say, oh, you have lupus. And when the patient was referred to rheumatology, so we, performed the differential diagnosis, and we found the patient actually has hypothyroidism, which resulted from Hashimoto thyroiditis, and patients do not have lupus. This makes a lot of confusions to the patients. So because they were told you have lupus, then they just got labeled. when they come to the rheumatologist and they said, we don't believe you have lupus, and they get really confused. It takes a lot of time and explanations to get them, off that label. So since we talked about the anti-nuclear antibody test, so we'll just use this sample to show you the technology, how the anti-nuclear antibody was tested. So here you have a cell line or cells grow on the glass slide. Then you add the patient's serum, which contain the antibodies in it. So the antibody will bind to the nucleus in the slide. Then you add on the secondary antibody, which is something against the human Ig, human immunoglobulin. And for most of the time, we are detecting IgG forms of those autoantibodies. So in this case, normally with labeled with fluorescence, then you can visualize those positive staining under the microscope. And so if you look at the test report, you can see they will give you some patterns. So those are the common patterns being shown here. So the first one called homogeneous means that they equally stain the nucleus, and some of them speckles is stain some part of those nucleus antigens, and some of them, like in the peripheral, they only stain some of those in the close to the membrane of nucleus, and some of the stain, like called nucleoli, and even more specific for centromere. Those patterns have been associated with all different autoimmune diseases. So, so here is another example showing you in the real, those are the real examples of the cells being stained with the patient's serum. Then you can compare with the previous, like a cartoon shaped of picture, give you some ideas how to recognize those different patterns. And nowadays, most of those autoantibodies or autoantigens can be extracted. Means you can isolate the different nuclear antigens, then you can classify which is specifically, and also quantify the antibody titers to specific nuclear antigens. Since we mentioned about antibodies or autoantibodies, so I'm going to discuss a little bit more about antibodies, because this is a really become a common, like a phrase nowadays. Because of the COVID pandemic, and you heard about when you get vaccination, how much antibodies you have produced. So those are the antibodies. Okay, Andrew, you have a question?
Yeah, so I assume with the immunostaining, the anti-nuclear antibodies are attached to specific nuclear proteins. Do you know if there's a link between, if say they're attached to, like, say, a polymerase or repair, or any number of ligases or the histones or whatever, if there's a relationship between that and the type of autoimmune disease?
Yes. So you mentioned about the polymerase, because there's specific diseases like interstitial lung diseases can be associated with certain autoimmune conditions like polymyositis, dermatomyositis. Antihistone can be found almost every single lupus patient. But on the other hand, if you have high titers of antihistone antibodies, most of the time is associated with drug-induced lupus. So that really is interesting thing. And also, if we do detailed tests, we can detect anti-double-strand DNA antibodies, which is more associated with lupus. So the anti-nuclear antibody test is kind of a screening test. Once you find it positive, and depending on the titers of the antibodies, and the lab will automatically perform, they call it ENA, extractable anti-nuclear antigen antibody test, including anti-double-strand DNAs. And each different ones will have the association with the disease. Like we have SSA, SSB means Sjogren syndrome antigen A, or Sjogren antigen syndrome antigen B. So they are associated with Sjogren syndrome. Yeah, there's a lot details about those ones. So anyway, so let's move on to the antibodies. So so antibodies are important molecules for us to protect us from getting infections. That's primarily what the antibodies will do. And you guys heard about like neutralizing antibodies. They can neutralizing the COVID spike proteins, therefore can protect you from developing the COVID. So the antibodies are basically glycoproteins, and they are produced by B cells, but the B cells have to be differentiated into the terminal cells called plasma cells. So once the B cells encounter the antigen, either a protein or other large molecule like nucleotides, they need to make some changes in terms of the morphology and the molecules. Then they decided to produce that produce antibodies to that specific antigen. So this is the like a kind of a detailed molecular structure, but I think the other slide I can show you, you know, in the teaching immunology, we refer like a Y-shaped molecules. So you have the heavy chain and light chain. Maybe the next slide is showing better. Like this one. So the dark blue ones we call heavy chain, and light green we call light chains. So they bound together by the different bond. They stick together. So in addition to the physiological functions, you know, against microbes, and also in the autoimmune diseases, they can produce antibodies against the host components, so-called autoantibody causing autoimmune diseases. So you can use antibodies as a research tool or tool for making diagnosis. Like I have shown you in those previous slides with the rheumatoid synovial tissue, and you can stain with different markers like a CD3 or CD20, and identifying either T cells or B cells. Those are the so-called immunohistochemistry staining. They need to use those antibodies. So this CD3 and CD20 are basically recognized by antibodies against CD3 and CD20. And I think I look at the record Dr. Xie talked about flow cytometry, which is a very useful assay for not only for research, but also for diagnosis of diseases, in particular in oncology or hematological oncology, you can really identify a single cell with certain abnormalities on their cell surface protein expression. And those flow cytometry assay is really antibody-based detection system. It's just like shown here. If you have a cell, and then you can have, so this is immunohistochemistry staining. So you have tissue with different type of cells expressing different antigens, then you can detect by this. But if you look at this as a cell, you can have the antibody against a certain molecule on the cell surface, then labeled with the fluorescence. Then you can go through the machine, recognize each different cell types, so that you can differentiate them and count them, even how many cells there. Even more popular nowadays is called a therapeutic monoclonal antibodies. And I'm sure you have heard about this monoclonal antibodies against COVID spike proteins. So they are clinically available, have been used. As a matter of fact, I just prescribed the monoclonal antibody IV infusion to a patient of mine this week. She has rheumatoid arthritis and she caught COVID, unfortunately, because she is considered to be an immunocompromised host and is eligible for receiving those monoclonal antibody therapy. So the antibodies given to the patients actually just like what you would produce by vaccination or even by the infection. The difference between so-called monoclonal antibodies and the antibody you produce is the number of antibodies you produced by yourself or by vaccination or infection will be polyclonal. So this is another different concept. So polyclonal versus monoclonal. Polyclonal actually is a mixture or cocktail of monoclonals, because once you get into the host, many B cells get encountered antigen and produce different antibodies. So-called clone is like each clone means it's coming from a single B cell. When the B cell divided to different sister cells and go on. But all this also called offspring cells will produce exactly identical monoclonal antibodies to a certain antigen. That's monoclonal. I think the next slide I'll show you how the man-made monoclonal antibody will be made. So I mentioned about the research tool. You can do other immunoassays, which I don't have the slide showing here. Like in the lab, you can measure a certain molecule by using two different antibodies. So means with one antibody catching the molecule, then you can detect the molecule by another antibody. So those all based on the monoclonal antibody technology. So the monoclonal antibody technology was invented by these two scientists. They were awarded Nobel Prize in 1984. What they have done is, so this is how you make antibodies for your research. So you inject the antigen, normally it's a protein, into a mouse, and the mouse will react to that injected antigen, and then they produce antibody to that. As I mentioned, they would produce so-called polyclonal antibodies. So polyclonal antibody can be used, but there's a lot of disadvantages. We still have polyclonal antibodies as a tool for research, but monoclonal antibodies is much more useful in many ways. Okay, so here the created really clever ideas how to make the monoclonal antibody. So the isolated spleen cells, which including B cells or plasma cells, and they fused with these cells called myeloma cells. And so the B cells can produce antibody, and the myeloma cells are the cancer cells. They can live forever. So that means you fuse them, they have the fused cells will have both the characteristics of B cells and myeloma. Means they can live forever, and they can also at the same time produce antibody. In this way, you can isolate each fused cell called hybridoma. Then you can isolate the protein from which secreted the antibody. That is the monoclonal antibody. Okay, so here are the modern ways to make therapeutic monoclonal antibodies. As we mentioned, so you immunize the mouse, and the isolated B cells from the spleen, then fuse with the myeloma cells, and it produce so-called hybridoma. Then you separate each individual hybridoma, then you collect those antibodies, then you test for the different antigen or different antigen epitopes. Because these are the protein from the mouse in origin, and they are not so useful as the therapeutic antibodies. What you need to do, you need to make some modification to those molecules. And the first therapeutic antibodies is called chimeric antibodies. So in this way, what you do is replace majority of the antibody, the molecule sequences with human sequences. And at the time, the technology was not so advanced, and this region called antigen binding or hypervariable region was not changed because the limitation of the technology at the time. If you change the sequence in those regions, and you will change it antigen specificity. So those were left, not changed. So that's why they call it chimeric monoclonal antibodies. And these two antibodies, I give you example, one called rituximab, the other one called infliximab, are still very useful clinically for treating different conditions. Like infliximab is used for treating rheumatoid arthritis, rituximab treating B-cell lymphomas, like CD20 positive B-cell lymphomas, and also being used for treating conditions like rheumatoid arthritis, and sometimes treating lupus and vasculitis, like inflammation of the vessels. Then with the advancement of the technology, and you can do much better. It's called humanized monoclonal antibodies. Means much more of this sequence in the hypervariable region gets replaced with human sequences. And these ones have much less reactions. Our body have much less reaction to those because they are more human. And again, those are the antibodies I'm listing here are they currently being used for treating various rheumatic conditions, including rheumatoid arthritis, psoriasis, psoriatic arthritis, ankylosing spondylitis, and so on. So yeah, so this, this part of the technology has been quite useful, and even more so nowadays, you can making so-called human antibodies. So you can use this technology called human transgenic mice. So you using the transgene from human B cell and antibody molecules, then you can have this mouse B cell produce totally human antibody. Then you hybridize with this human myeloma cells, then produce hybridoma, which will produce fully human antibodies. So nowadays, almost like all these newer monoclonal antibodies are coming are like a human in origin. So these are the monoclonal antibodies used in the clinical for treating COVID, but they are from different technology like this one. Okay, I'll go with that. So you can also produce human antibodies by using this like a phage display technology. So phage is actually a virus for bacteria, and because bacteria you can culture, they can grow, but you infect the bacteria, and with the phage will carry the human antibodies. Then you can amplify and purify, get the so-called human antibodies. And this is the third way you can make human antibodies. Means, for example, this patient had a COVID infection, and they produce antibodies to the spike protein. Then you isolate, well, you took the blood and isolate the B cells. Again, using the same principle with the flow cytometry, and I think Dr. Xie mentioned about the cell sorting. So based on their cell surface antigen or protein expression, you can use a specific antibody to recognize them. Then you separate them into different tubes. Then you can culture each individual the B cells, then get the antibody molecules sequenced. Then you make RNA, you can make a cDNA, then you can amplify that. Then you make fully human antibody based on those single B cells. The reason you have to use this because you wanted to have the antigen specificity from the person who produces antibodies. Then you can screen each of the single B cell producing antibody and make sure they are neutralizing antibody. Then you grab the sequence and amplify that. Then started to make those monoclonal antibodies. Then you can, like in the current application, they are using so-called cocktail antibodies. So they are not only one monoclonal, they are using several monoclonal together. So each monoclonal will bind to different part of the molecule, and therefore they can increase the capacity of neutralizing the virus or the protein. I guess this is the last slide. So really, so because is this kind of a technology using antibodies is really advanced. There's many things can be done by using the antibodies, and making therapeutic monoclonal antibodies is really extensive or intensive areas of active research, and the is good business for the pharmaceutical companies, and also is really benefit for the patients. But only problem with this is that just cost is too high. There are many monoclonal antibodies against so-called immuno checkpoint inhibitors. So for treating cancers. So what happens in cancer patient is their immune system gets like blocked by those checkpoint inhibitors. Now you are making the monoclonal antibodies against the checkpoint inhibitors. Means you are release the brake of the immune system, and the immune system become active. Then they can be functional to attack the tumor cells. But the things is always like you have the good side, also have some like not so good side. So those treatment created some problem for those patients, because you are like reactivate the immune system, and the immune system become overactive, and they can develop autoimmune disease. So those immunotherapy for oncology really is like opposite to what we wanted to do as rheumatologists. So we wanted to treat patient by suppressing their immune system. But the oncology for immunotherapy is really try to stimulate or promote the immune response to the tumor antigens. But again, we are still not as smart as supposed to be, or we want to be. So in autoimmunity, we kind of suppress immune system as whole. We do not have so precise, immunosuppression to those bad immune response. And similar is true in the immunotherapy for oncology. You bring up the whole immune system, get some reactivated. Therefore, you are inducing overreaction. Then they have the side effects causing autoimmune conditions. And we have seen quite good number of patients who have been developing like arthritis, even lupus-like symptoms after they receive the immunotherapy, also called anti-checkpoint inhibitor therapy. So it's complex, but yeah, it's interesting. All right, I think that's all the slide I have. So yeah, unfortunately, the other guys are not showing up, so we do not have interaction. Hopefully, they would understand something. And Andrew, with your help, maybe you can answer some of the questions, or something like that.
So I had a question. This is probably a little bit too advanced in terms of technology-wise, but I assume the monoclonal antibodies are against the anti-nuclear antibodies, and not against a very specific T cell, B cell receptor. So we're not just suppressing those particular immune cells, we're just going after the antibodies?
So I think I have slides showing what we used for treating rheumatoid arthritis called
Yeah.
abatacept, which is okay. This is related to the checkpoint inhibitors. So the molecular and
Oh, you'll need to hit share screen again.
sorry. Where's my slide? Here. Right, let me go back to. All right, so okay, I took it back. This is not a monoclonal antibody. This is a fusion protein. Is the CTLA4 fused with human IgG-Fc fragment. So CTLA4 is expressed by activated activated T cells. So when CTLA4 expressed, it will compete with CD28. So CD28 bind to a molecule called CD80/CD86 on the antigen presenting cells. What it does is it's called co-stimulation. So when the T cell receives the first signal from antigen binding to T cell receptor in combination with MRC on the molecule, they get the first signal and the T cell get activated. But in order for the T cell get fully activated on action, you need a co-stimulation signal. That's come from CD28 interaction with CD80. Okay, but on the other hand, you do not want to have the T cell over activated. It comes to a mechanism called checkpoint inhibitor. Okay, so CTLA4 is only expressed on activated T cells. And because its affinity binding to the CD80 is much higher than CD28, it will compete the CD28 off. Then you keep the T cell activation at a certain level, not over, but not too low. So they just like maintains like homeostasis kind of thing. I think that often time I put an example like you're driving a car. So you initiate the engine, that means like you have the T cell receptor engaged and get T cell activated. So that's your engine is on, but in order to drive the car, you have to press the gas. That's come from the co-stimulation of the T cell. But you don't want to overspeed. So then they come to the brake. So the CTLA4 is really like you put on the brake, and then you keep the car going smoothly, not over speeding. All right. So there's a treatment for that based on the monoclonal antibody against CTLA4. Okay, this is belong to the immunotherapy with a checkpoint inhibitor antibodies. So that means you kind of block the brake for the T cells. So you released the brake and T cell getting activated. Like what I mentioned, if you block the inhibition mechanism of the T cell, they can overreaction. And this abatacept is really using the property of CTLA-4 with a high affinity binding to CD80. And what it does is opposite to the oncology use. So it will bind to the CD80, and that will block the further activation of the T cell. So this is like a specific. And on the other hand, on a different way, this is might be the better example to show the monoclonal antibody. This is rituximab I mentioned, is the monoclonal antibody against CD20. CD20, as you know, is specifically expressed on the B cells. And in this way, once the antibody binds to the B cells, they can get the B cell killed. So you kind of wipe off the B cells, and then you become a specifically therapeutic for that. But again, you do not have the way to differentiate which is autoimmune B cell, which is normal B cells. You kind of wipe off all the B cells. So we still have a lot, thing to do to get more smart, to get more precise.
Yeah, that's sort of, I kind of figured we're at that point where we could get the individual cell surface proteins, but I didn't think, we were quite at the point where we could specifically go after one particular variation of a cell of a protein. So, specifically the ones that were expressing the the anti-nuclear antibodies specifically. So
right.
But I guess that would be the silver bullet, because you could just kill those cells and then you'd be okay.
Yeah, I mean, it's pretty much like what you give so-called like chemotherapies. You're killing all the active cells.
Yeah.
And tumor cells versus and the
so is this more of like a sort of it's not a cure, but it's more of a treatment to help reduce the symptoms?
Yes,
just to suppress the B cell activation, or getting rid of some of the activated B cells?
Yes, actually it works pretty well for like rheumatoid arthritis and vasculitis.
Right.
And you can get the patient into remission.
Okay, cool.
In this case, actually,
So you could actually get rid of enough of the B cells. The non-activated ones aren't harmed too badly. It's just the ones that are activated get knocked down to a level where it effectively goes. That's cool. That's cool.
Yeah. So so even more like precise in oncology, because the like lymphoma or leukemia cells express CD20 and they get killed. So this is much better than the chemotherapy without discrimination. You
because it's much more specific to the lymphoma or the leukemia.
Relatively more specific for the tumor cells.
Yeah, definitely.
Yeah, for each individual tumor, you need like a tumor specific antigen to produce antibodies to that. So
that's the problem with cancer.
Yeah, unfortunately, you don't have those specific antigens available now. Yeah, this is the best we can do so far.
Yeah, but it's still much better than about 20 years ago, though.
Absolutely. I mean, 20 years ago about rheumatology, rheumatoid arthritis, we kind of had almost like nothing but like a corticosteroid and methotrexate have been on for some time, but
I remember when PCR first came out, that was a big jump.
Right. The PCR now.
I was doing molecular biology not too soon after PCR came up, and that was a big deal. When that came about, it was like, whoa.
Yeah.
I mean, we were still growing up, plasmids and bacteria because that was cheap. But in terms of like duplicating and testing, it's
Yeah, you don't
Yeah,
need to
it's
do
great.
that anymore. So it's just yeah, get the
Yeah,
sequence and
PCR has taken
PCR that.
over.
So the PCR is like a daily living thing now. So
Yeah, it's like, you talk about these technology shifts, and PCR was one of those moments where things just changed.
right. Yeah, like we detecting the COVID virus. I mean,
Yeah, it's all yeah,
all PCR based.
yeah,
Yeah. So I mean, like Kyler, you guys are very fortunate. I mean, to be in this era
yeah.
with the advanced technology.
It's kind of like pre and post antibiotics. It's that big of a change.
Yeah, exactly. Yeah.
So yeah, I'm just like, it's cool to see that change happen in your lifetime.
Yes, exactly. I mean, I see the changes
Yeah,
myself.
I remember when the thermocyclers were like these magic things that cost a whole mess of money. And
Right.
now we have one in our cell biology lab, and we do PCR. Just like, oh yeah, we're just gonna do some PCR here in our undergraduate 100 level cell bio class.
Exactly. Yeah, yeah. You give the protocol the like
Yeah, it's like no problem. Yeah, it was PCR up. Yep,
right. The
whatever.
high school student can run it. Yeah, that's really cool stuff.
Yeah.
All right. So, Kyler, do you have any questions?
Not too much about this topic,
Okay.
but I was wondering if I could like ask you like what does like your daily life at like work look like, or like are you more in the lab or like with patients or
Um. Okay. So my daily routine, I guess, pretty messy. It's mixed with everything. Even in the clinic, I would, if I have moment, I would answer emails, questions from research, from administration, from teaching. So because I do almost everything for a physician in academic setting. So I see patients officially scheduled is a 1 full day and 1 half day. Um, then every week, 1 half day is devoted to education. It's not only like a teaching, it's like a including myself education. So we call it grand round, which once a morning. But the patient care stuff is never end. It doesn't mean like you are off the clinic and you have nothing to do with the patient. It's always you have something to do with that. So you need to check the patient medication list. You need to check the test result. And nowadays, with patient can get access to the medical record to get the test results. They often have questions, and they will send you a message to that, and you need to answer that. And I need to answer their phone calls. You So sometimes I have to initiate a phone call myself from my end because I find something I need to let them know, or say, for example, they have the test results showing some abnormalities which need to be solved. Uh, you cannot wait for that, so I have to call them or send a message to them, something like that. So in the clinic, sometimes I would have learners from medical student to visiting physicians, those including residents, fellows, and I do give lectures to various levels of learners, from medical students, PA students, residents, fellows, other physicians, community doctors and so on. And the other big chunk of my time spending is on research projects. So I have a lab, I think I mentioned to you guys at the beginning. So we are performing bench-based research. So we need to perform experiments, analyze results, and summarize the results, writing papers for presentation publications. And we have to apply for grant for supporting the research. And I also have administrative duties. So I'm sitting in different committees. One of the committees I'm actually doing is called ICOC, the Institute Animal Care and Use Committee. Means if an investigator wanted to do animal work in live animals, they need to submit a protocol which get reviewed by the committee which I'm sitting. So then we give comments, either rejected or we approve, or we make comments. You have to make modification for that. And I'm also sitting in the editorial board, and as one or two journals, I'm as associate editors. So it means the other people submit their articles for publication. I need to find people to review that. And I also review grant applications. It means somebody send a protocol, we have to review and see this is good, this is bad, or whatever happens, then we meet together to give the recommendation for the grant giving body. So yeah, so I do quite a few different things. Oh, the other thing I did not mention, I do clinical trials too.
I have like a follow-up question. So like since you like visit or like in this like COVID time, do you like go to the clinic or like your lab in person every day, or do you also do like telecare with like your patients?
Yeah, it's called telemedicine or telehealth. So we do this kind of visit like what we are doing. So on Zoom, say for example, we can interview each other. Say for example, if you are a patient, I can just ask you a question now. Then I can perform limited physical examination. See, for us, I mean, primarily we want to look at the joints. So whether the joint gets swelling or not. We now running this kind of hybrid mode. So with certain time, I go to clinic to see patient in person, and they come, because not everybody wants to come to clinics now in person because of a COVID, and so we don't want to have the patient exposed to the COVID by coming to the clinics and so on. And we also do phone visits. So it means we can just have a conversation with the patient on the telephone, and get history and assess how the patient's doing and whether we need to have more blood tests, whether they need to change medications. And the other way to do it is on the they call it my chat. It means like an email text, you exchange messages on those messages. So then, yeah, so multiple different dimensions we can take care of the patients.
Would you say you do telemedicine like more than in person?
We used to. Now we are doing I think about half and half. Yeah, so gradually we'll open to be doing more like a face-to-face visit than the telemedicine. But the likelihood will be we will incorporate telemedicine into our daily practice. So that means for many patients, we probably don't have to see them in person all the time. Actually, yeah, this is a pretty like a interesting and good things, all from this. It's a COVID pandemic really promotes the telemedicine now, and so we probably will incorporate more of telemedicine in the daily practice on this.
Yeah, it seems like it would be more convenient for like both sides sometimes. If it
Yeah, so I mean, telemedicine has been in practice for quite a long time, but not so widely used. It's pretty useful for those like people living in remote areas. In Oregon, in particular, is a lot of people live in quite distant, remote areas, and especially in the wintertime. See, for example, I have patients in like a Central Oregon. They don't really want to drive over, to Portland for visit. And in the past, we did not do telemedicine, and we either have to like have them have the long intervals for visit, or in combination with the local doctors for managing the patients. And nowadays we can just do some of the visits with telemedicine.
Yeah, that's great. It's 7:10, and if Andrew, if you don't have any more questions, then I think that's all.
Yeah, I'm okay.
All right.
Right. Okay. So
Oh, thank you very much.
yeah. If you have more questions from the other guys, when they listen to the record, you can email me.
Yeah. Thank you so much, Dr. Chu.
All right. Take care.
Bye.